Recently, I was honored to sit down with good friend and colleague Peggy Tighe, principal at Powers Law. Peggy is the policy brain and chief strategist behind the Seniors Timely Access to Care Act and the Regulatory Relief Coalition, both of which aim to reform how insurance companies use a process called prior authorization. Prior authorization is an administrative process intended to protect patients and payers alike from the burdens of unnecessary healthcare costs. However, prior auth has increasingly been used by insurance companies to deny patients care. Peggy joined me to talk about her work on prior authorization, what new regulations from the Biden administration mean to her ongoing efforts to stem abuses by insurance companies, and the future of the Seniors Timely Access to Care Act.
Thanks, Courtney. Thanks for having me here. I am excited to talk about this because I come from two very strange worlds in prior authorization. So I started my career at the Health Insurance Association of America during the advent of managed care, when managed care started to blow up. And I remember learning at the feet of some masters who were teaching me that healthcare was too expensive and that physicians just ordered things because they could, and it was going to bankrupt the entire system. So we needed managed care. Managed care was important. It was an economic control on overutilization, right? So it made sense to me. And I went out and worked with the Health Insurance Association of America and sold that message. I ended up in chambers of commerces around the country, and there was always a doctor. There was always a doctor in one of those rooms who raised his hand or her hand and said, "Do you know how difficult managed care is? Do you know that I can't get the patient the care that they need?" And it was frustrating. It was humbling. Here I am, this young lobbyist lawyer person thinking, boy, I know everything now. I know so much about the insurance industry. And what I didn't know is the impact of managed care. Fast forward a couple of years, I end up working as a lead lobbyist for the American Medical Association, and boy, did I learn about prior authorization there, because every physician I talked to made it very clear to me how painful, how difficult, how much harm could be caused to a person when prior authorization was delayed or denied altogether. And so that brought us to a place of, I think the pendulum has swung in such a way that managed care kind of overdid it. It's not a bad concept, but they kind of overdid it. And that's speaking gently. And my providers would say they way overdid it. And the pendulum is now swinging back the other direction, where it should be a more reasonable middle ground. So you have utilization review, you have tools like prior authorization. When they're used appropriately, when it's transparent to the providers and the patients what the rules are coming from the insurance industry, then we're going to get down to that middle of the pendulum, if you will, so that people aren't being delayed, having delayed care or denied care, which always makes them sicker and more expensive, frankly, to the insurance industry or to the government payers. So we know there's a happy middle ground, and I think we're in a better place because of the legislation we're advancing and the rule that just got finalized to get to that better place.
So we're gonna talk about that rule in a second, because I want to understand what the implications are and how that's going to change the legislative outlook. But you implied by a happy middle that there is a good reason for utilization management practices like prior auth. That, and I think you alluded to that in, insurance companies saying that doctors may over order or over prescribe. Is that still happening? Is that still a reason for prior auth? What are some other reasons for prior auth?
Yeah, in the last 20 or 30 years, a lot of things have inserted themselves into the process. So, for example, physicians have been measured on quality far more than they ever were in the past. Litigation is tough. If you're getting sued and you're a physician, you're going to order every test to make sure somebody doesn't come back and sue you for not ordering a test. So it's not because there's just bad doctors or there are doctors who are trying to game the system. They really are trying to provide the very best care for their patients, but they're hamstrung by these other things. Quality measurement, I'm sorry, I shouldn't say is a hamstringing factor. It is a good thing that we are trying to raise up physicians to a place where quality is predictable and good, and providing people with the care that they actually need. So there's many different ways of care, MIPS, and there's all these other systems and blah, 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 blah. Are all of them perfect? Are all of them right? No. But I'm glad that there is that quality measurement that has been instituted. We can't act like it's 1997 and there are no such things. There already is a balance in that direction that would favor the insurance industry, right? It's not just the doctor over ordering everything anymore, because they can't. They can't and get paid. So that, I think, brings us to a place of how is information relayed and transferred. So a huge part of the rule in the bill that we're going to talk about is the transference of information by faxing is ridiculous. It is not 1997. I mean, this is crazy that anybody's faxing anything to anybody. I tease my colleagues at work who have their fax number on their business card still. I'm like, what's a fax? The 20-somethings don't even know what a fax is. So why
Don't
is
say that.
why is it that we're doing that? So I was just actually reading the rule again and looking through and seeing what the rules are for faxing and these other methods of communication that are from the dark ages. And what CMS has said is, we get it. There are still payers out there who are receiving information by fax from maybe that doctor, that elderly doctor, or works in a rural area, and he's got his, single shingle, just him running a practice or her running a practice. They don't want to do anything other. They're not doing an API. They're not going to a portal. It drives them crazy, right? Now, just let me practice medicine. I just want to practice medicine. Why are you making me do this crazy stuff? So the bill and the rule, as I read them, do not make providers use this crazy stuff, the APIs and others going forward, but it does require the payers to use it. Payers should be far more sophisticated. We're talking Cigna and Aetna, the big guys know how not to use a fax, right? They also have to understand that their customers, and the providers and the patients are their customers, should be able to use the means that effectuates their ability to get the decision made about whether they can have the service. It is not balanced on purpose, nor should it be balanced, because there are underserved areas, for example, where people are still using those methods of communication. Can we ease them into a more electronic world? Yes, we should. And that's exactly what the rule says. That is the attempt by the government to do that on these federal programs.
That's really interesting, because I think a lot of the policy that we've seen around, optimizing care delivery has sort of forced these things on, that single rural provider. So, what I hear you saying is that the CMS, the regulation that was recently passed by CMS, intends, at least to your reading, to make things easier to get the right answer.
Mm-hmm. Yeah, and that's really the whole goal. I mean, when we started the Regulatory Relief Coalition, first thing we did is we went to the former administration and said, hey, people aren't getting care. There's these delays that are going on forever and people aren't getting the care. And I remember one of the staffers said, and I won't tell you who, well, you have an appeals process. And I thought, that's adorable. What do you mean? The appeals process it does nothing on delays. It has nothing to do with delays, and it has nothing to do with the transparency of what are the rules. Just tell us what the rules are. Every physician I've ever talked to, nurses and others, have all said the same thing. Just tell me the rules. But playing the game of send me another fax, or I didn't get your information, or call me, or make sure your medical director calls me. All of that was a gaming of the system by some of the insurers to delay the care and keep the money in their own pockets. I mean, let's be honest. We know what it was.
With the expectation that at some point, somebody in that process would run out of patients. Yeah. Either the patients and their family and caregivers, or the providers who are sort of doing all of those communications.
Yeah, that attrition kept money in the insurers' pockets. and continues to keep money in the insurer's pockets. And if you're a business, you want to keep money in your pockets. You make your own judgment call on whether that's appropriate, okay, or is has a good value system behind it. I won't, but I think you know my impression.
So you mentioned the Regulatory Relief Coalition. I imagine that that's a pretty diverse group of stakeholders. Who do you have at the table? Who cares about this other than insurers? And I think that we understand now their motivations here.
Yeah. So RRC,
or some of their motivations.
Yeah. So RRC, Regulatory Relief Coalition.org, by the way, if you want to look us up, started with the ophthalmologist and the neurosurgeons. So two of my friends from my AMA world, and I went to them and said, why aren't we doing regulatory relief? 10 years ago, we were talking about regulatory relief. Nothing ever went through Congress. We spent all this time running around Capitol Hill on regulatory relief, and I don't see any regulatory relief. Why don't we do our own? And so we went to the administration and said, the way we read the law is that Medicare beneficiaries should be getting the same care as Medicare Advantage. We know they're not. We know they're not. So we found a problem with the law, wrote a legal analysis, told them that, and then we started talking to folks on the Hill. So medical specialty organizations are the ones who comprise RRC. We're now 14 members strong. It's a whole plethora of different groups, American College of Surgeons, dermatologists, and all the a bunch of the medical specialties who have been with us through this venture and through this fight. American Academy of Family Physicians also is a member. And that is a medical specialty to my mind. I know some people don't think that, but I know that to be true. So we work collaboratively as RRC. So RRC is just medical specialties, but we have the RRC allies. The RRC allies are folks who are not medical specialties who care deeply about this. So folks in the cancer community, proton therapy folks, Premier, other organizations who said, well, can we be a member of your medical specialty coalition? And we said, well, you're not a medical specialty, but we'll make this place for you. Beyond that, as we traverse through this 6-year or so journey, we were able to enlist over 500 endorsing organizations from the state and the federal level. So of our universe, if you will, of supporters of what we were doing with that bill are 500 plus organizations, including the insurance industry. What did you just say, Peggy? Didn't you tell me you used to work for them? Why on earth would they support this bill? The Better Medicare Alliance came out with a statement, and this was not accidental. It took a lot of work from a lot of people to convince them that this is the way of the world. This is where it was going, and they needed to get behind it before they were under it. And I think that was part of their calculation from the Better Medicare Alliance, which represents some of the largest insurers in the country. Since that time, we've been told that individual insurance companies not only have endorsed the bill, but they have endorsed the practices that we were espousing. And what's happening in the rule, they saw it coming because we helped make it through our bill. They saw it coming and they're responding to it as an industry. That's a rare occasion where you're able to pull your enemy, if you will, into your camp. And that happened because we wrote a bill by talking to them. We actually had many communications with them back and forth with Blues and AHIP, the National Trade Association for Health Insurers, that was the predecessor to HIAA. HIAA doesn't exist anymore, but now it's AHIP. Anyway, we talked to those groups over and over, and the Hill staffers we were working with talked to those groups over and over. And we thought we found a reasonable middle ground that was common sense, as evidenced by the fact that those insurers never put out messages that were in writing on their websites or otherwise opposing our bill. They didn't oppose our bill. Blue Cross Blue Shield made some noise about it, but there was no formal opposition to our bill. That took years of work to hold them in that place.
Well, and I want to come back to that because I have a feeling that some of that is very relevant to the conversation that we're going to have around the CBO score, which I think is sort of the next hurdle that we have to get past. But I want to come back to some points that you made earlier on about sort of how all of these things are interwoven together, because one of the things that happens a lot in our world is you get a particular piece of legislation on a policy issue that's entirely unrelated.
Mhm.
And somebody says, well, this is going to drive up utilization management.
Mhm.
The example that comes to mind right now is Medicare drug price negotiations.
Yep.
That was passed under the IRA. So, I mean, those are two very different things. Why would somebody be able to say Medicare being able to negotiate drug prices is going to drive up utilization management? Why? How does that work?
It was a very frustrating exercise. So we knew intellectually, academically, that when you give people care, it's going to cost less to the system, right? So we were out selling our bill and saying, well, it couldn't possibly be a score. We don't see a score. And CBO, Congressional Budget Office, came back and said, it's $15 billion. We went, what? You got to be kidding. Well, in that Congress and in this Congress in particular, spending money is a problem. There isn't a whole lot of money to go around. What the heck are we going to do with that score? So our bill didn't pass because the Congressional Budget Office came in and said, hey, you're gonna score. It's going to cost money to implement what you're trying to implement. CMS, the Centers for Medicare and Medicaid Services, in their proposed rule, reached the exact opposite conclusion. Exact opposite conclusion. So the agency that knows the most about healthcare, CMS, said it's going to save money and we're going to show you how. And they did tables and analytics and support and all this other stuff. And we still have CBO over here saying, yeah, but we think it's going to cost money. It's been the most frustrating thing to deal with when CBO can kill a bill in Congress. They have certainly stalled our bill. I'm not telling you they're going to kill our bill, because we're going to ratchet that cost way down. We're already down to $4 billion, which is still too high, but it's a lot lower than 15.
So do you think that's because CBO knew that the insurance companies weren't living up to the letter of the law? And the CMS proposed rule was a little bit more optimistic, or were you seeing the opposite happening? As you said, the insurance companies were starting to play ball and starting to agree with the changes that you were proposing and maybe implementing some of those changes on their own.
Well, speaking of black boxes, and we talk about, prior authorization as a black box, we also think of CBO as a black box. There was a hearing in the House Budget Committee last week where a bunch of members made much more pointed remarks about CBO than I'm making right now. So it's been called into question that we really don't know how CBO is determining their methodology for how things and why things should cost. But what they've told us is that where an industry has to do something new, they will raise the prices of that product, or in this case, a service. And therefore, the government is going to have to pay more because they're going to raise their prices, which is interesting because the whole concept of drug negotiation is trying to get that industry to not raise their prices, but that's a different story. So yeah, that is the working assumption from the CBO, is that you're going to have an industry reaction. What I think is most interesting is the industry reaction is the opposite. The industry reaction has been, we're on board. We're on board. We're already doing some of this, and we're going to do more, and we're going to do it better. And I think that competition comes into the idea. Medicare Advantage patients can pick their plan. They pick a plan and decide who does better on prior authorization. The most telling statistic I ever saw, and in the multitude of studies that have come out analyzing Medicare Advantage, was the one that said, when do people leave Medicare Advantage? It's the last 2 years of life. When are you sickest? The last 2 years of life. When are you not getting the care you need? The last 2 years of life. I'm no economist, but I have a feeling that we learned from that study that people run from Medicare Advantage because they're not getting the care they need. So I think the industry went, oops, we better fix that. And I think they are reacting in the right way. So I question, again, putting this as nicely as I can, because this might be in print. I question the methodology of CBO. I think they should take a hard look at what CMS concluded.
And I think that your comments about Medicare Advantage are particularly interesting, given that we just saw the first year of higher participation in Medicare Advantage than traditional Medicare, that more seniors are opting into Medicare Advantage plans than relying on traditional Medicare services, plus maybe a supplemental if they can afford it.
Yep.
So there's a lot of money to compete for there.
Mm-hmm.
And I think, your points about transparency are well taken. I think that these are things that need to be thought about very carefully when you are picking your MA plan. So, I mean, we've talked a little bit about the bill and the rough road that you've had so far. And we talked about the final rule a little bit too. Why was this so important? Was this the turning point that you hoped it would be? Where do things stand now?
So where we stand now is having conversations with CBO. So that's not me, that's the Hill staffers and leadership in the Senate and the House, trying to convince them academically that when something is now required under a rule, the price for that bill should go down. CBO told us that. So if something's already going to be required, then the CBO score shouldn't be at that high number. We're talking about different provisions of the bill and that CBO has identified as costly, and trying to reconfigure them to make them not costly. That's the whole exercise right now. And then we're talking about hopefully a joint House Senate reintroduction of the legislation. So if I have a rule, people ask me, why do you need a bill, Peggy? Well, I need a bill to codify the rule. Laws are stronger than regulation. And in light of the potentiality that the Supreme Court is going to rule on in the Chevron case, look it up. It's kind of interesting stuff. Not you, Courtney, but your audience. Is that some of things that the agency does where they may or may not have regulatory authority could be challenged. So if I have a law that says, you can't challenge this, my bill matches the rule, then we're safer. So passing this law is everything. And we're going to keep fighting as hard as we can, fingers crossed this year, to get it across the finish line.
I think that the last two questions that I had are really sort of what's next and what can people do to help.
Yeah, so we've gone through the long history, or relatively short history if you think about it in congressional time, of moving a major piece of legislation. Normally it takes about a decade, and we've been at it for 5 or 6 years. And that our legislation has now influenced a major rulemaking, so that's pretty impressive, I think, for 6 years. And we pulled in the right team to go fight for this. One thing I didn't mention that was, I have these waking dreams. I forgot to thank so-and-so, right? Thank God I'll never get an Oscar, is choosing the right staff. So choosing the right offices and choosing the right staff. Sure, yeah. So you want to choose, if you're trying to move a bill, a committee of jurisdiction, somebody who's on the committee of jurisdiction that could actually move your bill. So that's step one. So doing that, we knew this bill would go to the Ways and Means and the Energy and Commerce Committee. So our first choices were people from the Ways and Means Committee and the Energy and Commerce Committee. And Charlotte Panetta, her boss was not on either of those committees. So why did we pick Dr. Marshall in the House when we first introduced this bill? Because Charlotte's a dynamite staffer. Yep. So she had so much energy and excitement, and she begged us, please, let me be on this, let me do this. And it was probably the best decision we made, because she's a worker. She worked this bill like nobody else. So anybody else out there who's trying to advance any kind of legislation in Congress, find that motivated and committed staffer. That motivated and committed staffer can make all the difference in moving your bill. You can find a great member of Congress who sits on the right committee, and they have a staffer who is a deer in the headlights and doesn't know how anything works on Capitol Hill, and you're dead in the water. And we did the opposite.
when I first started out, there was a cadre of like health staffers who just knew everything. And, yes, there was the committee staff, but you would go into offices and to a person, every health staffer at least knew what you were talking about.
Yep.
And it seems like post ACA, post MACRA, post, a couple of administrations where folks really felt sort of disenfranchised. I don't know.
Right.
The harder that it's gotten in the Hill to get things done, the more atrophy you've seen, I've noticed in that muscle, that
Yep.
healthcare muscle, and those really good staffers.
Yep.
So how do we fix that, or how do you find those people?
It's tough. It really is a vicious circle. So you have members, a lot of members retiring, especially in the House, when they don't get to be in the majority, or they're seeing that they're not going to be in the majority. There's a lot of retirements. There's a lot of retirements for other reasons too. So those staffers of good members who are looking for another job, or they're, staying on the Hill if you're lucky, or they're taking off. Also, Hill staffers aren't paid as handsomely as they used to be back in the day, right? So when I was breaking into lobbying, there was, a couple people who you just would kill to know because they had 20 some years of experience. And it was hard to get to know them. I remember bemoaning that, like, how am I ever going to break in? How am I ever going to break in and know those people have been doing this for 20 years? Because that's who I want to work with. And then everything changed. And now you have to re-educate and re-educate and re-educate all day long a whole new cadre of staffers who oftentimes don't know anything about their history and their past and the congressional process, procedure, and all of that. And it makes it harder. It makes you more valuable when you know more than they do, but it makes it a lot harder. To spend your time, spend your life as an educator. Lobbying and advocacy is education, first and foremost, without question. And as you're educating, the first lesson is don't talk down to anybody. Oh, were you around 20 years ago? No, they weren't. They were in grade school 20 years ago. Don't talk down to these young staffers. You gotta, listen to their ideas. Have you thought about this? Have you talked to the parliamentarian? Lead the horses to the water. Don't shove their face in the river. I think you've got to be subtle and careful with them, because if you're not, you're going to get some angry staffers who feel like they're being treated like their grandparents are telling them what to do. So for younger lobbyists, no fear. You will build relationships with people because there's a lot of churn, as they say on Capitol Hill. With that said, come armed with procedure. And as Judy Schneider, her former CRS person, would say, know your P's, know your process and your press and your policy and your procedure. And if you don't, you're not going to be of any help to those people who are struggling to learn not just the issue, but how to move an issue. Not kidding. I saw this the other day. I got an email from some random group saying, we do AI for lobbying. And what we'll do is produce for you an edit to your amendment in the middle of markup that you can hand to a member of Congress. What? There's a subtlety, there's an ability to understand where both sides are coming from about what you should give up and what you shouldn't give up that is part and parcel of this job. And that if you're not, I can't make this up. I just talk to my clients to make sure my clients are willing to give up something. I've had more than a few occasions where lobbyists have just said, yeah, let's go. And then the client's livid and fire them. What are you doing? There is so much more involved than just AI spitting out, here's your compromise. It was laughable, absolutely laughable.
Well, if AI can write music and make movies, I'm sure it can lobby.
Yeah, but that brings me to where we are right now with regulatory relief. So we've got a rule, we've got a bill, and our coalition has put together a chart that is pages long that describes the differences between the rule and the bill. So what happens now? We have to modify our bill to make sure that it is working with the new rule. How much do we modify the bill? How much do we take away from it? How much do we add to it? Is the very big question at this moment. What are the key points about that is if it increases the score, that's a bad idea. We don't want to add anything that increases the score. We don't want to take away anything that increases the score, but it's more the former than it is the latter. Will we lose endorsements? Will we lose co-sponsorship? Will we bring on the insurance industry opposition? Those are really important things. So if there's any changing that's going to happen to the Seniors Act, it has to go in line with those kind of 5 things. Is make sure we're not losing any stakeholders, make sure we're not getting any opposition that we didn't have in the past, make sure the score is going down. This is the toughest
but
year
also
we have
preserve
ever
the
seen.
integrity of
And
what you're
preserve the
trying to
integrity
accomplish.
and the policy, and don't undermine the rule that just came out, because the rule does some things better than the bill. The bill does some things better than the rule. Where is the middle ground between those two things? And honestly, our champions haven't decided that action plan yet. This is what we do to help them get to a place of that compromise that, again, AI can't do.
Right. So when you have that compromise, and I'm assuming, because I've known you forever and I know how good you are at your job, that you are getting feedback from, yes, your stakeholders and your clients, but also getting broad feedback from patients and providers, and learning how this will impact them, and getting that information. What do you expect from those stakeholders? What can they do to help on the other side of this? When you have that bill, when you're ready to go, what are the next steps? Are we going to get it done this year?
Right. This is all, again, part of this journey that you go on with your stakeholders. So I had somebody who told me, my constituents aren't happy with the bill and the rule because it doesn't go far enough. It doesn't stop prior authorization in its tracks. And I giggle to myself and I say, well, that's adorable. We were never going to be able to eliminate prior authorization. I'm sorry, I couldn't do more for you, but I still think it's a watershed moment in insurance and provider relations that we're making the insurance companies be transparent about what prior authorization is and how it works. So win your battle. It's a big battle and it's a big win. But there are going to be detractors out there. Other people have said, well, the insurance industry will find ways to get around this. Yeah, they will. Mm-hmm. And the idea is, well, then what else are we going to do? Well, let's just stop. If everybody throws up all these brick walls to you and you just knock it down brick by brick, because otherwise you don't have a choice. You sit back on your hands and go, wow, that's right. We can't do anything then. Well, that's silly. You got to have some optimism in working with the Hill, the government, and the stakeholders to get to a place of we're sticking that camel's nose under the tent for the better. And ultimately, it's all about the patients. It is all about making sure the patients are getting the care that they paid for, that the taxpayers are paying for, and that they need.
And policy, at least it used to be, is iterative, right? I mean, you try something out, you see what's working, you fix the things that aren't working. Mm-hmm. I think the big legislation in sort of our lifetime in health policy, it was never meant to be one and done. I mean, we make changes to the Medicare program every year. Right. Why do we think that the Affordable Care Act is just going to live like, oh, it was perfect? We can't ever touch it. And if we do, it means that we're admitting failure, or we're supposed to be able to iterate. We're supposed to be able to learn from our mistakes.
Yeah, Social Security, Medicare. I mean, name a law, and I can't think of one that hasn't changed in some way, shape, or form. They do change, and that's incredibly important. And so your how you advocate and how you keep advocating and how you it's not the Super Bowl. You don't win the game and go home. You win the game and then you go work on the other battles that are coming afterwards, right? So that's where advocacy is so important. So what are you doing in advocacy? Let's say you're a patient, let's say you're a provider. Are you working with your national association? What is your national association? Is it the umbrella group of the American Medical Association, American College of Surgeons, or is it a medical specialty group for the physician side, or nurses? You know, there's nurse practitioner organizations, there's all kinds of other groups. They have tools to help you be better advocates. Regulatory Relief Coalition has tools for you to be advocates. You can go to regrelief.org and tell me your story about prior authorization. People are going to my website. They're looking at it. Reporters are looking at it. You want to be quoted by a news source? That might happen. We're collecting those short stories in a social media kind of platform so that we're feeding the debate going forward. Same thing for patients. Patients can always tell their stories. Not in 14 pages. That's not going to help anybody. I'm sorry. You got to be really succinct to capture anybody's attention in information overload world that we live in right now, but a succinct story about something that is wrong and a way to fix it. And it's not just the something that's wrong. We have a whole lot of noise out there. Let me tell you how wrong everything is. The first level of smart in my mind is being a devil's advocate and talking about how something can't work. The second level of smart, which is a higher level of smart, is the creativity to be able to fix that problem. That's what members of Congress are supposed to do for you. Help them do that for you. Identify for them that you want the seniors bill to pass because it'll help your problem. It'll help other people who are facing your problem going forward. That's the connection. In law school, they taught us it was applying knowledge. You're applying knowledge to the problem and building a path forward to fixing that problem.
And I just want to emphasize that point because, if you are a patient going to your member of Congress with a problem and a solution, it is literally their job to help you. Mm-hmm. It is literally their job to show up and say, okay, I understand that you are experiencing this difficulty. How can I help you in the short term with your acute problem? But also, wow, you are part of this wider network who is working on creating an infrastructure so that this doesn't happen to another person. Right. How can I be a part of that? Mm-hmm. They're looking for ways that they can demonstrate value to you because you are a constituent. So, being educated and using the resources that you have available is one of the best things that you can do as a patient and a patient advocate.
On any issue, but on this issue, we have over 500 organizations. I bet you're connected, you patient provider or otherwise, are connected to one of those associations. Look it up. The Arthritis Foundation. There's plenty of patient groups. If you have a particular condition, they're probably endorsing the bill. And if they're not endorsing the bill, let's get them to endorse the bill, whatever disease group is focused on that. I know our friends in the cancer community are hot on this for lots of really important reasons, like cancer kills and you don't have a whole lot of time. So hurry. Let's hurry and make sure people are getting the care they need before the cancer's spreading. I mean, that seems like the most obvious thing in the world to me. When you think about it, is delays to line the pockets of the insurance industry just really, really ain't okay when you're in a beat the clock kind of situation.
Anything else that you would like to add about Seniors Timely Access to Care Act, or the rules that came out, or what we have to look forward to by the end of before the end of this Congress, and we're going into a presidential cycle?
Yeah, well, I am hopeful that this rule came out, a bill will be introduced. We will go gather a whole bunch of co-sponsors. That bill, the seniors bill, as probably modified, could advance, if we do it right, this Congress. But we can't do it alone. We have to have people from out in the world saying you want it. If you don't want it, those Hill staffers are like, I don't know, nobody's talking about it. Talk about it. Please talk about it. Even if you're just on LinkedIn, for God's sake, say, read about this bill, seems important. Why isn't Congress moving it? Let's help. That simple, that kind of 20 seconds of thought to put in a message out to the world. Talk about it at a cocktail party, talk about it with your friends. Those are the real simple things you can do easily. Then it's an escalating level of engagement. You could go directly to your policymaker. You could say, hey, where's this bill? I read about this. I'm excited about it. I see your names on it. How is this going to move? Can you move this year? Really simple communications have such an impact. Nobody's asking you to write a 16-page summary of the bill compared to the rule. We're just asking you to weigh in and talk about why this is important and why Congress needs to do it. Congress has a limited time this year. It's an election year. They don't usually do big stuff. This is one of the things they could do because it is bipartisan. Democrats and Republicans both support it. It is bicameral. It's in the House and the Senate, and the White House agrees to it. Oh, and by the way, we have all these supporters. It's got the secret sauce to actually move this year, but it's going to take advocates like you, I hope, listening to this podcast to push it over the finish line.
Well, thank you, Peggy. This has been amazing. And I look forward to seeing what happens this year. I'm very hopeful that this is something that we can finally get done.
Thank you for what you do. And any questions or thoughts from your audience, I'm happy to take them.